This is Dr. Shakil Ahmed. Today I want to discuss ovarian malignancy and how to diagnose and to differentiate. As we know, ovarian cancer is the fifth most common cancer of the woman, and it is the leading cause of death from gynecological malignancies. Unfortunately, the ovarian malignancy has late presentation. 85% of ovarian cancers present in stage 3 or stage 4. And the average age for presentation is approximately 63 years. About 25% of ovarian cancers are bilateral, involving both ovaries. 10% are associated with the hereditary syndromes such as BRCA1 and BRCA2, which carry risk of breast cancer, and also Lynch syndrome 2, which carries risk of colon cancer. Patients with endometriosis are at high risk. The risk of ovarian cancer increases with age and decreases with number of the pregnancies. The oral contraceptives has protective role. Screening for ovarian cancer, especially with pelvic ultrasound, is not a standard practice. The tumor marker CA125 is non-specific, and it can be elevated in other benign diseases such as fibroids and endometriosis. This is transabdominal image, which shows an enlarged ovary with complex cystic formations. This is the uterus, and this one is urinary bladder. This is transvaginal image. Here, the high resolution image shows multiple cystic loculations with solid components and septations. Another TVS image of that ovary, it shows a complex loculation with internal echoes and also here a mural nodule. Applying the color Doppler shows the presence of blood flow within the solid components. By application of the spectrum analysis, the peak systolic velocity is 17.6 centimeter per second, while the end diastolic velocity is approximately 6.3 centimeter per second. The resistivity index is calculated, and that was 0.53. So the pattern of the flow is low resistance. In this low resistance flow is typical for new vascularity of the malignant lesions. How to diagnose the ovarian malignancy? Any complex lesion that enlarges the volume or the size of the ovary. Any lesion that contains solid components or mural nodules, they are suspicious for malignancy. Presence of vascularity in the solid component is very much indicative of malignancy. Thick nodular septations are present. The size of lesion is not important. What are the differential diagnoses? First of all, dermoid tumors or dermoid cysts. Dermoid cysts contain complex loculation and echogenic components. Dermoid cysts demonstrate shadowing from calcification or dirty shadowing from fat. Dermoid cysts do not have internal vascularity in the solid components. Hemorrhagic cysts are also to be considered in differential diagnosis. Hemorrhagic cysts are complex masses with retracting clot that may mimic solid components. These retracting clots are often concave or contain straight lateral margins. No internal vascularity would be seen in a clot or lesion. Take home pearls or message that solid component is the most useful criteria or feature of ultrasound. The presence of solid elements, internal vascularity, and thick nodular components are signs of malignancy. Although ovarian malignancy is associated with larger masses, the ultrasound features are more useful predictor of malignancy than its size. Thank you for watching.